think we'll get started. Good evening, hello to everyone, and welcome to this AO Spine North America webinar. This evening's topic is strategies for fixation in osteoporotic bone. And as probably all of you know, this is a vexing problem for us and a growing problem for us demographically around the world. We have joining me tonight, Steve Theiss, who's the chair and professor of orthopedic surgery in University of Alabama, Birmingham, and a good friend of mine. I really appreciate you being here tonight, Steve.
Oh, sure. Looking forward to it. Thanks for the invitation.
These are our disclosures. I don't think that you'll find any of them are relevant to the stuff that we'll be talking about tonight. And just to give you an overview of this session, this will be case-based discussion, primarily between Steve and I, and targeted toward practicing spine surgeons who have to treat these patients. And so we'll talk about what we found are the most up-to-date and predictable strategies for optimizing fixation when you have to fix the osteoporotic spine. My hope is that when we're done, you'll be able to identify the most common failure modes in fixation in osteoporotic vertebrae, understand that you have some options to improve the chances of success, and be able to implement them. And so tonight's webinar will revolve around two cases. One that Steve Theiss will present to us. We'll go through that and have some discussion around that. And then I'll present a case that I had from a few years ago that was quite challenging. We'll talk about that and then wrap things up. Before we move on, though, I just want to do a little bit of housekeeping. Your microphones and cameras you'll find are muted, and chat has been disabled. We can't, because we have so many participants, we can't have the raise your hand function tonight, but you can place questions in the Q&A box, and either Dr. Theiss or myself will try to address them if we can, even try to bring them up in the session if we can. So please be as interactive as we can be within the constraints that we have. So I'm going to stop sharing my screen and let Steve take over for a while.
If I haven't figured this out by now, I'm in trouble, huh? So, and again, we've disabled the chat function, so put your questions in the Q&A box. You can't raise your hand either, but Ted will monitor the Q&A while we go through this case. We're going to try to have a little discussion ourselves about this case as well. But specifically what I'm going to talk about is I'm going to talk about an osteonecrosis case involving an osteoporotic fracture, as well as some strategies for preoperative optimization of bone health. So this case centers around a 74-year-old gentleman who has a past medical history of hepatitis C, which has led to cirrhosis. He's diabetic as well, but his diabetes is fairly well controlled. His A1C is 6.2. He was ascending a set of stairs, missed the first step, reached for the railing, couldn't grab it, and fell back, landing on his buttocks, and then came to the emergency room really complaining about back pain. At the time, he had no neurologic symptoms in his lower extremities. He had no numbness, paresthesias. He was motor intact. He had no incontinence or any other sequelae of any kind of neurologic injury. His radiographs initially, when he was in the ED, are what you see here. So you can see he has a degenerative spondylolisthesis, and these are supine radiographs. He has a degenerative spondylolisthesis at L4, L5. But the main acute finding that you can see up towards the top of the lateral radiograph, not so much seen very well in the AP, is you can see that he has a compression deformity of some sort of the T12 vertebral body. At the time at the emergency room, they went ahead and they got a CT. So you can see a mid-sagittal cut on your left-hand side and an axial cut on the right-hand side. And, you know, the first thing we want to do, obviously, when we see a fracture of some sort is we want to try to classify it to help us understand it and help us understand the various treatment options. And I'm sure many of you are familiar with the AO thoracolumbar trauma classification. If you're not, just simply put, A is some kind of compression mechanism, B is some kind of distraction mechanism, and then C would be like a translation or a shear force. And then there's various gradations and subclassifications within that, you know, but very clearly, you know, this is a compression type injury based on the mechanism, based on the imaging that you see. And as a matter of fact, most of the osteoporotic fractures themselves, and if you feel like that inferior end plate at T12 is intact, that would make this an A3 fracture, according to that classification. If you feel like that maybe that inferior end plate's not intact, it would make it an A4. But clearly, I think we all know that these osteoporotic type fractures are distinctly different than a high energy injury. And so recognizing the difference between an osteoporotic or an insufficiency type fracture and a high energy traumatic injury, AO Spine, in an effort to better classify these injuries, came up with this osteoporotic fracture classification. And I thought it would, obviously relevant to our case, I thought it would be a good idea just to review this and help you understand the distinctions. So the validity of this classification is still being investigated, but essentially it divides these osteoporotic fractures or these OFs into 5 different types. OF type 1 is a fracture where really on X-ray or on CT, you really can't see any deformity of the vertebral body. These are usually what we think about as occult fractures. They're diagnosed on a STIR MRI or a T2 MRI when you see some edema in the vertebral body, but that's an OF type 1. OF type 2 fracture is where there's deformation of one end plate with or without minor posterior wall involvement. So you can see it can be the superior end plate, it can be the inferior end plate. There can maybe be a little buckle in the posterior wall of the vertebral body, but in general, there's minimal posterior wall involvement, but that's an OF type 2. And these are increasing severity, as you can guess. OF type 3 is now there's deformation of a single end plate, but now there's distinct posterior wall involvement. And you can see in the small print, it says with posterior wall greater than 1/5 involved. So it's more than just kind of maybe a buckle of the superior posterior corner of the vertebral body. Moving on to OF4 is where now there's deformation of both end plates with or without wall involvement. And that's important because now there's no structure of the vertebral body and it's very prone to vertebral body collapse. The classic pincer type fractures included in this. I'm not sure you can see my pointer, but when there's actually a coronal split in the vertebral body, very susceptible to non-union disc material, soft tissue can get trapped in there. And then finally, the most severe osteoporotic type fracture is this OF5, where now there's a failure of the tension band, whether it be an extension injury with failure of the anterior tension band or a flexion distraction type injury with failure of the posterior tension band. But now, particularly with the decreased support of the vertebral body, they're very, very prone to kyphosis. So just to kind of return to this fracture, just looking at it on the CT and on those initial films that we have, this to me looks like that there's some distinct posterior wall involvement. There's involvement of the superior and maybe the inferior end plate. So I put this initially at an OF type 3 or OF type 4. That same ER visit, they got some standing radiographs prior to discharge, and here's standing radiographs now. And so you can see now there's been some distinct collapse of the vertebral body, and this is really just between supine when he originally entered the ER and standing when he finally left. And as a result of that, because of concern potentially for some type of posterior ligamentous injury, this MRI scan was obtained. You can see the edema of the vertebral body. You can see the retropulsion of the posterior cortex. But the other thing you can see is that there's really no increased stir signal in the posterior ligamentous complex. So there's not a distinct posterior ligamentous injury. but clearly standing, there is some kyphosis there. So I think that that's a description of the injury. Familiarize yourself with that classification for sure. It can be very useful. And as this case rolls on, you can see how it's useful in this instance in trying to guide treatment. The first thing that we do when we see patients that have fractures like this is we assess their bone quality. And so early on in this gentleman's treatment, he was sent for a Dexa scan, and you can see in the Dexa scanning of his spine that he has a minimal, his worst T-score is -3.2, and that mimics also the bone density in the femoral neck where he has a T-score -2.9. So here's someone who's clearly osteoporotic with an osteoporotic type fracture and insufficiency fracture. And then so I'm going to now kind of bring Ted into the mix. And this gentleman comes, he's comfortable, he's up walking around. He is neurologically intact, and now he comes for your counsel as to what you want to do and how you want to treat it. And I've listed some options here: non-op, brace, no brace, vertebral augmentation, kyphoplasty, vertebroplasty, or surgery. And so, Ted, I'll give you a minute to peruse and think about it, and then tell us your thoughts about it.
Yeah, Steve. So we see these patients obviously with some frequency, and if they can ambulate safely, their pain is controlled enough, especially if they have some help at home, we'll offer to let them go home and follow them a week or 10 days later in the office. Some of the patients will need a brace, but we don't require these patients to get up with a brace. If they feel comfortable enough to try to sit up and stand up without a brace, we'll let them do that. And to be honest, years ago, when I first started practicing and I forced all of these patients into braces, a substantial number of them would wear the brace out of the emergency department and then not wear it anymore because it was too uncomfortable for them. So, to me, brace is a matter of comfort. If they are not comfortable enough, when we try to get them up in the emergency department, then we'll try fitting them for a brace. We almost never treat immediately with cement augmentation. We try to get these patients up. If they can't ambulate safely because of pain, we'll admit them for 1 or 2 nights and see if just giving them a day or two is good enough to allow them to get up and start ambulating before we would consider kyphoplasty or vertebroplasty. And we certainly don't take these patients to surgery immediately. So for me, I'd be looking for what's the route to get this gentleman to be able to go home. If he has adult children or he has a spouse who can help him, that's what I'd be looking for. And the question of a brace would be a matter of comfort. What brings him greater comfort?
Yeah, I agree. And that mimics my thoughts exactly. I wanted to ask you, and I know it's not the subject of this webinar because we're talking about fixation and osteoporotic bone. But what are your indications for kyphoplasty and vertebroplasty, particularly, in light of, for the orthopedic surgeons that are watching, I'm sure you're aware of the American Academy of Orthopedic Surgeon practice use guidelines that really suggests that vertebroplasty, as a result of a prospective clinical trial that initially showed no difference between a vertebroplasty procedure and a sham procedure. And I know there's some problems with that study, and it's been repeated, and those results are not always duplicated. But what are your indications for a vertebral augmentation procedure, and do you do any of them now?
Yeah, I do. And you're right. Back around 2011, 12, when the AAOS came out with that practice guideline, I personally, I have some real problems with the strength of those 2 studies that were published in the New England Journal of Medicine. I think we have a growing mass of data since then that would point to some utility for vertebral augmentation in some of these patients. And so I do kyphoplasties generally when I do augmentation. I do that because I think it's a little bit safer procedure, because I'm creating the cavity that I'm going to put the cement into, and it's, at least my feeling is, it's a little bit less likely to leak out through fissures in the vertebral body. But I reserve that procedure for the patients who can't, after 1 or 2 overnights in the hospital, still can't achieve enough pain control to be able to get up and ambulate safely. So those are the patients that I would indicate for an augmentation.
Yeah, and you're absolutely right in that the data does show that cement extrusion and embolization is significantly higher for vertebroplasty than kyphoplasty. Mainly because you're putting that cement in under pressure in a vertebroplasty, whereas a kyphoplasty, because you've created that cavity. And that cement embolism can be morbid. There's complications related to that. There's been incidents of cardiac complications, pulmonary complications. Of course, we know if it extrudes into the canal, obviously the potential neurologic sequelae. So, but yeah, indeed, we did choose non-op treatment. No brace for this gentleman. He was up ambulating and at least initially seemed to be doing well. There's a question in the chat. One of the participants asked, when I get a Dexa scan, do I always check the spine and the femoral neck, or do I just get the spine? And what I'll tell you is that we always get multiple body and anatomic regions, particularly the spine in patients that may have some spondylosis. There's sometimes sclerosis of the vertebral bodies. If there's degenerative disc disease, the end plates or any kind of spine deformity can affect the bone mineral density. So what you're looking for is in the various anatomic regions, you're looking for the worst bone mineral density that they have. And then that's the number that I use when I'm either screening or trying to optimize these patients preoperatively. So this gentleman then came back at 2 weeks, and here's his 2-week follow-up. His pain's improving. He has no changes in his neurologic exam, but clearly you see that he's had some progressive collapse of that vertebral body. His kyphosis may have increased slightly, though he feels like he's doing fairly well. He's still ambulating. He's active, and at this point, despite the progressive collapse of the anterior part of the vertebral body, we chose to continue to treat him non-operatively. And that was coming along well until he came back for his 10-week follow-up. We saw him one time in between there, was doing similarly to 2 weeks, but and I'm going to show you a close-up here. So now here he is at his 10-week follow-up, and you can see that he's developed, in my view, osteoporosis of particularly the anterior portion of the vertebral body. You can see that he has vertebraplana there. There's very little bone there. And obviously with this progressive kyphosis, he's had increased pain. And now we're to the point where we're going to maybe have to take a different strategy, because he doesn't feel like that this is sustainable with the pain that he has. If you kind of look at that pathology of that anterior portion of the vertebral body, he has what's referred to as Kummel's disease, Kummel. Sometimes there's 2 L's when you see it spelled, sometimes a single L apostrophe S, and that's essentially osteonecrosis of the vertebral body. And it's characterized by intravertebral cleft. Don't quite demonstrate it on this CT scan, but you'll very often, either on an extension film or a CT is obviously usually lying down an extension, you'll see some gas or some air within the vertebral body. That's essentially pathognomonic for osteonecrosis or a non-union. But very clearly you can see almost complete osteolysis of the anterior part of the vertebral body. So now we're left trying to figure out what our options might be and how we're going to specifically try to address this. We'll go back and kind of talk about treatment for that and how we approach that. But wanted to digress a little bit and just talk about the medical evaluation and optimization of bone quality. One thing that the literature is very clear on is that patients with low bone mineral density in general with spine stabilization and spine fusion procedures have increased complication rates and a poorer outcome. There's very well established animal models of osteoporosis. Essentially, you can take animals and you can overrectomize them and take out their ovaries and create osteoporosis. And when you do that and you do a spine fusion, their fusion rate goes down. the bone mass that forms in the fusion is not as robust and it's not as stiff and the bone quality is poor. But it's really just not the fusion rate that's affected by low bone mineral density. It's also other complications associated with the stabilization and the fusion. And there's clinical studies and there's a whole host of them that have shown that there's increased incidences of adult deformity surgery of PJK and PJFs. Cages subside, you get adjacent level vertebral fractures that complicate it, you lose fixation. So clearly, patients that have lower bone mineral density do worse. So who do we evaluate preoperatively for their bone mineral density, and what do we do to optimize it? When I think about in my practice about who I'm going to evaluate preoperatively for bone quality, I kind of go back to the definition and classification of osteoporosis. So in discussing osteoporosis, really three types of osteoporosis have been identified. Type 1 is osteoporosis that's seen in postmenopausal females. So whenever I see a female that's over 50 to 55 years old, who's going to have any kind of significant stabilization and fusion, I just assume they're postmenopausal. Certainly patients that have had hysterectomies and had their ovaries out at an earlier state, at an earlier age, get sent for this as well, but they get sent for assessment of their bone quality. The other second type of osteoporosis is senile osteoporosis. That's when patients get older, the osteoblasts are no longer as active, and now there's an imbalance between bone formation and bone resorption. So any patient over age 65 who would qualify under having potentially type 2 osteoporosis gets sent to have their bone quality assessed. And then certainly patients that have osteoporotic fractures fall into that as well. And then type 3 osteoporosis is osteoporosis that's due to various comorbidities. And really that falls under kind of four main categories. One is medication induced. The typical ones are glucocorticoids, people that are on anticoagulation for a prolonged period of time, and proton pump inhibitors are the main medications. So people that are on those for a long time need to have their bone quality assessed. The second category of comorbidities is rheumatologic disorders, mainly rheumatoid arthritis and lupus. So make sure you check those. There's several endocrine disorders, hyperparathyroidism, hyperthyroidism, hypogonadism are the main ones, as well as diabetes. So any patient that's a significant diabetic deserves evaluation of their bone quality. And then malnutrition is kind of the final category. And now you think about people that have inflammatory bowel disease, celiac disease. Also included in malnutrition are people that may have had gastric bypasses for weight loss. Tend to see a lot of those in my area, but Ted does too. But they need to be evaluated as well. So these are the patients that I see that are going to have a fusion, that are going to have instrumentation and significant spinal realignment that get sent to get their bone quality evaluated. And the tests that I get are this: get a serum calcium. You'll see in a minute that while we always get that, very rarely is it out of whack, and that unless patients maybe are hyperparathyroid. But I also check a 25-hydroxy vitamin D, check a parathyroid hormone level, and I'll get a Dexa scan. And so kind of just let's talk about each one of these things and what we can do to optimize them, and does optimizing them really do any good as far as our outcome is concerned. As far as calcium is concerned, we know that females, when they are postmenopausal, or patients that are over the age of 65 need calcium supplementation. And you can see some numbers there. It varies between 1,200 milligrams and 1,500 milligrams a day. The average diet gets 600 milligrams, so they're gonna need some kind of a supplement. And we do this just as not just preoperatively for spine fusion, but all patients we see in the clinic, we give them this advice. The interesting thing about calcium is that while there's some animal models that show that supplemental calcium may increase the fusion rate, there's really no clinical studies that show any improved outcome by supplementing calcium in the perioperative period. So while it's important intervention to prevent osteoporosis, to think that you're going to give someone supplemental calcium and improve their fusion rate is not true. That it just hasn't been shown. On the other hand, though, vitamin D has been shown to significantly correlate with fusion rate and with perioperative complications. There's two studies that I'm going to highlight here. One is by Ravindra in 2015. He did a prospective study where he took patients that had a wide range of fusion procedures. It was all different regions of the spine, cervical, thoracic, lumbar. They had various types of bone graft. They had various levels fused, but he essentially divided them into patients that had high vitamin D or were vitamin D deficient. And he defined vitamin D deficiency, and this is how it's defined, as vitamin D less than 20 nanograms per milliliter. And he found that in the vitamin D deficient, controlling for all the other variables in the vitamin D deficient patients, they had an increased pseudarthrosis rate and a longer time to fusion. So, that shows that vitamin D supplementation is important. The other study, it was a retrospective study where they had a large group of patients. Some patients got vitamin D supplementation starting immediately after surgery. The other group of patients did not, and they found definitely a higher fusion rate in patients taking supplemental vitamin D. So I'll always check a vitamin D level in people I'm assessing their pre-op bone quality. And if that vitamin D is less than 30 nanograms per milliliter, they'll get vitamin supplementation. The vitamin D daily dietary requirement is about 1,000 international units, but in people that have vitamin D that's insufficient, so less than 10 nanograms per milliliter, I'll put them on 50,000 units of vitamin D a week for 6 weeks in an effort to raise their vitamin D up to appropriate levels. But it does make a difference because the studies are pretty clear that you need to optimize it in order to get a favorable outcome. Kind of the other category, or the first kind of category of osteoporotic medications are the bisphosphonates. And there's kind of a lot of controversy as to how to manage bisphosphonates in the perioperative period. You'll remember that bisphosphonates inhibit osteoclasts. If you think of osteoporosis as an imbalance between bone formation and bone resorption, well, if we inhibit the bone resorption, then potentially we can increase bone quality. And the animal models seem to show that bisphosphonates around the time of a spine fusion may actually show a more robust fusion mass. And this makes sense if you're not resorbing bone, but you're just laying down bone, that fusion mass is going to be more robust, but that bone isn't as high a quality bone because it hasn't remodeled appropriately. So the animal models seem to show some benefit, but the clinical evidence is really pretty weak. It doesn't look like that bisphosphonates hinder fusion, so it's not like that they create pseudarthroses, but if you think that keeping someone on a bisphosphonate is necessarily going to improve the result, the evidence isn't really super regarding that. I'm going to highlight one study, though. This is actually a prospective randomized study that you see where they had 2 groups of patients in a PLIF model. One was put on bisphosphonate, alendronate, specifically around the time of surgery, and the other just got a vitamin D control. And in their study, they did find that the alendronate group had a higher fusion rate, a faster fusion rate, and also had decreased complications like loosening of the screws, cage subsidence, etc. Those studies haven't necessarily been replicated in other clinical studies, but it is some evidence that shows that maybe a bisphosphonate can help decrease complications. Just kind of anecdotally, most surgeons stop bisphosphonates preoperatively and then start it in the post-op period after the first several weeks. I think that the clinical evidence shows that you're probably okay to keep patients on their bisphosphonate, and it's not going to lead to any kind of adverse outcome. We certainly don't use it, though, to optimize bone health before surgery. Kind of the most...
Steve, one point of clarification.
Sure.
Someone in the group asked, when you prescribe vitamin D, do you prescribe vitamin D2 or D3 or both?
Yeah, I tend to prescribe vitamin D3.
Yeah, me too.
Yeah. So, but I believe that vitamin D3 is a little more efficacious, but vitamin D2 would be appropriate as well. So kind of the most intriguing topic in optimizing bone health preoperatively is the use of synthetic parathyroid hormone, or the most common one is Pteroparatide. There's another available now, but this has long been known in the lore of spine surgery to potentially increase fusion rate and potentially decrease complications. And the more you kind of delve into the science of this, the more you realize that indeed that is the case. There's one group out of Japan that probably has the lion's share of clinical research on this topic, and some of those studies have now been replicated in other regions of the world. But one I'm going to show you is this prospective study of patients that were divided into 3 groups. One group was given Pteroparatide, and they started a few months before surgery, and then they just kind of picked an arbitrary amount of time after surgery. They kind of had it for about 8 months. And then the second group was a bisphosphonate, and the third group was a placebo. And they found that certainly the group that got Teriparatide did have a faster fusion rate and less complications, less screw loosening, less cage subsidence. I did find this meta-analysis and systematic review that was just published this year that looked at the compendium of studies regarding Teriparatide. And again, they showed the same thing, that whatever kind of complication you want to look for in patients that have suboptimal bone health and they're osteoporotic, if you can get them on some Teriparatide or some Forteo is a trade name before surgery, you can decrease the complication, decrease their pain, decrease their sagittal imbalance. So the clinical data shows that it does have a good record for a improved outcome. The problem is that the dosing regimen is unclear. They're pretty much just kind of chosen out of the air, maybe give it a few months before surgery and continue it a few months after surgery. Really, the main problem in my world is that in people, unless they're severely osteoporotic, where it would be covered anyway for osteoporosis treatment, reimbursement for this is very, very difficult. Most places that do this effectively have case managers and case workers that have various tricks up their sleeve to get it paid for. It's very expensive. So, you know, someone with a T-score minus 2.5, if you want to get them on some Teriparatide, it's actually a relatively difficult thing, and it's a very expensive thing for a patient to pay for themselves. So
Yeah,
just
but it's getting better because there's now another competitor, a Balaparatide, and so it's becoming less expensive.
Yeah, I agree. You know, and whenever you see an athlete that has a fracture, right, they're usually on it, you know, so they can get back and play faster. So just getting back to kind of just some summary of pre-op optimization of bone quality, you need to test it for bone mineral density in patients at risk for osteoporosis. Definitely correct your vitamin D. You probably don't need to stop their bisphosphonates, but if you want to, you're going to be okay. You're not going to decrease their chance of success at all. But also know patients that get synthetic parathyroid hormone, you're going to increase their fusion rate and decrease their complications. So anyway, so let's get back to this case now. So we have this patient has osteoporosis, has severe collapse and kyphosis. And so Ted, maybe just give me your thoughts on kind of how you'd approach this, what you feel like your options are: fixation, bone grafting, anterior, posterior, or the like.
Yeah. So the failure of a construct is going to be at the bone implant interface. And so to me, your strategies need to be around improving the bone, the stresses around between the screw and the bone. And so cement augmentation is one way to address that. Another way to address that would be some sort of reconstruction of the anterior column. But that comes at some risk that whatever you put there could start to subside. But I think if you wanted to do posterior fixation alone, I think your best bet is going to be to use cement to augment the screws. If you wanted to try to get by, or you don't have cement augmented screws available, then I'd be thinking about ways to gain anterior column support, and that would mean either a transpedicular or a small costotransversectomy transversectomy or some way of getting in there to get a good load sharing anteriorly.
And I know you have some data in your talk about cement augmented screws and fenestrated screws versus cement, and then screws and cement. So we'll let you get to that. But so indeed, that's what I chose. So you can see that I did a relatively longer construct, right? 2 levels above, 2 levels below. You can see the cement augmentation. These screws are fenestrated, and that's how I applied the cement. the bone grafting aspect of it is something that is obviously important. The interesting thing is that if you look at the data of augmented fixation, as Ted said, instrumentation failure is not an issue, right? Very rarely do you see broken rods or you see instrumentation that fails. It fails at the bone implant interface. The bone grafting I chose for this was essentially just kind of intravertebral bone grafting. So there's a large amount of cancellous graft and augmented type of allograft that's packed into that space that's going to heal hopefully from top to bottom. But that was my choice here, and that was how I approached this case.
That's really good, Steve. I think one of the themes of this session tonight is going to be the power of cement augmentation to help us help these patients.
So I'm going to stop my share and let you go ahead.
Okay, I will share my screen again. All right, and I'll also start with a case that I ran into several years ago now, but it was kind of instructive. This was a 68-year-old woman with a long history of rheumatoid arthritis, and she had this mild degenerative scoliosis and some listhesis, but she developed atraumatic back pain and was diagnosed with this L2 superior end plate compression fracture. And she was not sent to me at that time. And so her physician ordered her, one of our radiologists, to do a cement augmentation. And so she had the cement augmentation done, and then her physician ordered a Dexa scan. And so this is kind of an interesting way to sort of get a spurious result, because as you can see, the beam that shot through L2 was attenuated by the barium in the methyl methacrylate, so that her T-score at L2 was positive 2.0, which is a spurious, incorrect result. And then, as you mentioned, Steve, there were some end plate sclerosis and osteophytes at L3 and L4. And so when they got, even though the beam that went through L1 got a negative 2.1 T-score, her average T-score was considered normal. And her physician thought that she no longer had osteoporosis. And so this is just a lesson to all of us to not just read the result of a test, but to look closely at how the test was performed so that we could avoid a spurious result. So this woman then went on for the next 2 years without medical treatment for osteoporosis, and with increasing pain and increasing dysfunction, and was confined to a wheelchair when she was sent to me. And she said, now she's 70 years old, and she said, my back hurts every time I move. I can't walk. If I try to stand up, I can't feel and control my legs that well, and it's so bad that I don't want to live anymore if I have to live like this. This was a representative cut of her T2 MRI scan, and you can see the collapse in the and the retrolisthesis at L2. You can see that she's got significant osteophyte formation and stenosis in other places, as well as the degenerative spondylolisthesis at L4-5. And so this represented a real challenge for me, because we have a patient who needs an extensive decompression. She has a pathologic fracture, a deformity, and she's got really pretty severe osteoporosis. Now, at the time, years ago, I had been running a series of experiments on screw fixation techniques in osteoporotic vertebrae. And so one of the first things that I did was to was to look at augmenting screws that were solid core screws, and I would make a pilot hole and put about a milliliter of cement into the hole and then sink the screw, and it was clearly improved fixation. We also did some finite element modeling of the effect of where the cement is with regard to the screw, and in the finite element modeling, it was clearly best if you could get, I outlined here in this orange box, if you can get the cement nearer the screw tip. And so over the course of several years, I tested many different manufacturers' screws. I tested fenestrated screws and injected cement through them. I tested solid core screws with cement placed in the pilot hole first. And from a mechanical standpoint, they were pretty similar. But to me, the technique of fenestrated screws was probably less risky because you could concentrate the cement further away from the canal. And it probably presented less cement flow problems when trying to get an even amount of cement around the screw. These are just some representative diagrams of those two different techniques. On the left is the creation of a pilot hole that we all know how to do, and placement of a fenestrated screw, and then injection of the cement through the screw, and it would extrude out through the fenestrations. On the right is the technique that I used to cement augment solid screws, and that is make the pilot hole, then tap the screw track, what we call line to line. So if you're using a 7mm screw, tap it with a 7mm tap, and inject about a milliliter and a half of cement into that hole, and then place the solid screw. Now, there have been many studies since the series of experiments that I published. All of them seem to concur that cement augmentation of screws is a very powerful technique for us. Most recently, I think this is a preprint before final publication, was a study this year that looked at the two different cortical screw tracks or trajectories versus traditional trajectory with cement augmentation. And once again, traditional screw placement with cement augmentation was significantly better than either of the cortical screw trajectories that they tested. There have been also this past last year, there was a group in Spain that randomized osteoporotic patients to either an expandable screw or a fenestrated screw with cement augmentation, and they reported equivalently very reasonable results with both groups, both technologies. But back to my patient, this was several years ago, and in the US, we didn't have fenestrated screws available. None had been cleared through the FDA. We didn't have expandable screws available. And so what we had were solid screws. And so the plan that I came up with was to do my wide and long laminectomies, decompressions, and to place each of the screws with cement augmentation. And then I just, at that point, she had enough surgery for the day. And so I placed a provisional rod, and then we brought her back in a stage 2 in the same hospitalization. And I finished off a subtotal vertebrectomy of L2. You can see the only thing that was really left was this the cement from her kyphoplasty on one side, and then I placed a peak spacer through the transverticular route, and then placed my my final rods. And so her course was not perfect. She had a wound dehiscence that required us to place a vac sponge, but we were able to get her wound to close and heal up. And these were X-rays with brace supplementation that you can see at 4 months. And so this patient who had come to me in a wheelchair was comfortable enough and had enough motor function to be able to walk into clinic. That was pretty gratifying. But when she was 1 year from this surgery, she felt a pop and new pain in her lower back. And this is something that I wanted to share with you. So I got a CT scan, I got X-rays, and I suspected what we saw, and that is she had a non-union at L2 with rod fatigue fractures bilaterally. And as you pointed out, Steve, very rarely in these severely osteoporotic patients do screws or rods break, because usually what fails is the bone implant interface. And yet, because of the effect of cement augmentation with these screws, what failed was the rod in fatigue when she developed, when her non-union timed out. And so, so I brought her back and re-bone grafted that area, replaced her rods, and this was her two-year post-op film, no brace anymore, and she was able to enjoy a much greater quality of life after that. So, so Steve, one of the questions that I have for you is, when you fix these osteoporotic patients, is there a role for a brace? Is there a role for physical therapy to you, or is that too risky? What are your thoughts about that?
Yeah, so I tend not to use braces, in adults. I just find that they're cumbersome. They interfere with activities and with ambulation. Patients, they're uncomfortable. They get sores from them. And I feel like if my construct's not appropriate to stabilize the spine or to hold the spine in the position I want it, that a brace isn't really going to do me much good. I'm aggressive about mobilization. I think the reason that you augment your fixation or use some of these alternative techniques is so you can get people out of bed and get them on their feet. It's such a critical part to bone health, first of all, but also to recovery from a significant operation. So I tend not to use braces. I very rarely use them really for any pathology in an adult, whether it be a fracture, where a large trauma centers see a lot of fractures, but I don't use braces with the exception of a cervical collar, but a thoracolumbar brace I think is cruel and unusual punishment.
So there's a question from the audience about the choice of cement, and I'll tell you, when I'm using fenestrated screws today, my strong recommendation is that you use the cement that the manufacturer has tested that will flow through their screw. I can tell you in my lab, we tested some screws with some cements that would not flow through the channels in those screws. And so you don't want to be in the operating room finding out that this combination doesn't work. So today, if I am using fenestrated screws, because the manufacturers in the US have only tested them with methyl methacrylate, I use the methyl methacrylate that they have tested. But I used in this lady, and if I use solid screws and I augment them, I prefer the bioactive cements like hydroxyapatite or calcium phosphate. And the reason that I prefer them is because they don't heat up as they set. And I have one patient that I didn't include in this slide presentation in which I used this similar technique, and I had extrusion through an unrecognized crack in the pedicle at L1. And when she woke up in the ICU the next day, couldn't move her leg, and I scanned her and there was a large amount of cement in the canal. just medial to the pedicle. And so I took her back to the operating room, and because I had used hydroxyapatite cement, there was no thermal damage to the neural elements. And I was able, with a small angled curette, to just pick out the cement. It had the consistency of like dried toothpaste. And so I didn't have to risk putting a burr right next to the dura to get methyl methacrylate out. And so from my standpoint, that's why those are the pros and cons of the two different cement options that you have.
And Ted, there's a question in the chat about why did you stage the procedure in this patient? What was your criteria for staging it? You feel like it helped with the outcome and improved the outcome?
No, I did it because she had been on such high doses of steroids for such a long time that she had pretty severe adrenal insufficiency. And so after we hit about 6 or 7 hours of surgery, anesthesia was having trouble keeping her blood pressure up. And that's why I decided to stop and stage it.
And do you give those patients stress dose steroids just out of?
Absolutely. Absolutely. So that's kind of not subject of this, but yeah, patients who have been on chronic steroids, if your anesthesia has any trouble keeping their blood pressure up, that should be your first move, is to give them stress dose steroids right then.
And another question about using iliac screws. So there, I see there's no adjunctive iliac fixation at the base of your construct. Can you talk about that? And
yeah, sure. I think in most of our adult deformity patients, I prefer to use pelvic fixation, but in the severely osteoporotic, you're going to a pelvic fixation will also need cement augmentation. In this patient's case, I really felt like we were not correcting a lumbosacral deformity. We were addressing a mid to upper lumbar deformity, and so you know, with the augmented screws at L3, L4, and L5 and S1, I felt like we had enough fixation, and as it turns out, that was correct.
Excellent.
All right, I think we addressed all of those questions.
Yep, we did.
And so let me move this on. So Steve, this has been enjoyable for me. I hope that the participants found it somewhat enjoyable and thought-provoking. This in no way it encompasses all of the issues around osteoporosis and fixation in the spine. There are a lot of other issues that we have not addressed tonight. There's some evidence around cement augmentation in the upper instrumented vertebra and the UIV +1. There are other aspects to this that we don't have the time to get into tonight, but I thought this was an interesting way to at least start talking about the subject. I want to remind that our participants that the Global Spine Congress has been redated to November 3rd through November 6th. There will be a hybrid meeting, so there will be an in-person aspect to the meeting. There will also be a virtual aspect to the meeting. And so you may want to look into registering for that because I think on the website now the preliminary program is available.
And just one final question came in. Now we've opened the door to PJK and PJF because we mentioned it. So we know that that's a difficult topic that everybody has a lot of questions on. But how do you approach adjacent segment disease in these patients? Do you quote unquote chase the PJK in these patients? Could you share your thoughts on how you handle this? Apologies if too broad of a question.
Yeah, well, I mean, I would just say in general terms, it depends on whether it's radiographic or it's symptomatic. And so I think most of us who take care of these older patients will see some proximal junctional problems that are you can see radiographically, but the patient seems to be doing okay. And those I really try not to intervene surgically on. The patient's symptoms drive me, and in the patient who who's become very symptomatic from it, then I sit down and have a long conversation with them that we can probably address this focal area, but we may still be at risk for the same process occurring again above, wherever we end our instrumentation. And so if I feel like the patient understands that and is a sort of a willing partner to go down that path, then I'll offer a subsequent surgery. If they don't seem to understand that we don't have the perfect solution to prevent PJK and PJF, then I'll just try to nurse them along until they come to terms with that.
Yeah, I agree with that. I usually try to augment the top of my fusion in some form or fashion. And there's a lot of different strategies for that. Some involve cement, some involve trying to disperse the force at the top. I find that very rarely that patients that have gone through a large adult deformity procedure are they anxious. In the absence of PJF, where they're at risk of neurologic injury, are they willing to, at least initially, early in the postoperative period, when you usually see these things, have a subsequent operation? So I approach it exactly as you said. You make them aware of it, you discuss it with them, you tell them the warning signs, you follow them, and then they usually figure out over time whether it's something that they can live with and something that doesn't necessarily affect their outcome or something that needs to be addressed. There's one other question in the chat about, do you use tranexamic acid or TXA for spine operations? And yes, I use it, essentially on every significant spine operation that I do. So, yeah,
I think that data has become pretty compelling. The data in the adult reconstruction literature is very compelling, and it's I think equally so now for large spine surgeries.
Yeah, I agree. Well,
I also want to bring your attention to upcoming AO Spine North America webinars scheduled later in the fall. In October, there'll be one on treatment for cervical radiculopathy, and in December, there'll be one on lumbopelvic injuries, and I think that should be very interesting. It's another set of kind of vexing problems.
Well, great. I'm just typing in a question that answered into the chat. Just says, if patients come with cord edema, is there some role to start IV dexamethasone but not infusion of methylprednisolone? Saw some papers that claim it has some benefit. I do not use steroids in the perioperative period if patients have myelopathy.
Yeah, I just haven't seen enough compelling evidence to make me do it, and there is pretty strong evidence of the systemic risks. So I'm with you, Steve.
So anyway, well, good. Well, certainly enjoyed it. Thank you, everybody. Thank you, Ted, for including me, and hope everybody has a good night.